effective, apparently, for visceral than for bone disease. So we think we're going to see a continued uptick in the number of tumors that we're responsible for. Despite improved survival from these systemic treatments, the role of metastatic treatment is still palliative. We want to improve and maintain neurologic function, achieve local tumor control, mechanical stability, pain relief, and ultimately improve quality of life. And if we get a result like this, a patient with a thoracolumbar burst fracture, pathologic from multiple myeloma, underwent surgery, and doing this 100-mile paddle in the Allagash River, we've clearly met those goals. This is a converse where we have these really complicated complications from treatment of tumor. This appears to be a radiation recall injury in the skin and then failed fixation. And this is obviously a horrible outcome in a patient with metastatic tumors that required a significant free flap reconstruction and a long posterior fixation reconstruction. And we do everything in our power to avoid these kind of outcomes. And basically everything we've done for the past 25 years is trying to get this outcome rather than this. The single greatest advance in the treatment of metastatic spine disease is stereotactic radiosurgery. It's defined as high-dose perfection conformal radiation, typically given a 16 to 24 gray single fraction or 8 to 10 gray times 3 fractions. Compared to conventional external beam radiation, which in the spine is typically given as 3 gray times 10 fractions, radiosurgery obviously has a shorter treatment time, but can actually give a cytotoxic ablative tumoral dose. And that fundamentally changed our treatment paradigms, including the indications for and type of surgery that we do. In combination with checkpoint inhibitors, about 20% of the time, we think we're beginning to see the abscopal effect where we give local radiation and get systemic disease control. And now there are multiple studies looking at oligometastatic disease, giving radiosurgery for up to 1 to 5 tumors that gives both a meaningful meaningful increase in survival and decrease in distant metastases. And so I think going forward, we'll see many more tumors being treated sort of in that asymptomatic series to try to, again, advance or increase survival and decrease metastatic tumors. There have been major advances in radiosurgery, including technological, defining tumoricidal doses and dose constraints for organs at risk, and even defining the radiobiology of radiosurgery. Here's a typical case example of a 66-year-old male with a history of renal cell carcinoma, had this biologic back pain for 3 weeks. Biologic back pain is night or morning pain that resolves over the course of the day. We think it has to do with inflammatory mediators that are secreted by the tumor. When you go to bed at night, you stop making steroids from your adrenal glands so that you can go to sleep. And so you get this flare pain at night. And when you get up and start moving and making steroids, that pain gets better. And it really denotes simply that there's active tumor, not so much mechanical instability or fracture pain. So this pain was biologic, but it was severe. It was 8 out of 10 at night. Acute onset of weakness. He was 3 out of 5 in the lower extremities. Had other issues going on, chronic renal insufficiency. Stomach workup showed renal cell extending into the renal vein and some pulmonary nodules. And you can see this really high-grade circumferential disease at T10. And I think when you look at this patient, it's just a really complicated group of symptoms and a lot of competing elements in terms of where you go with treatment. And many years ago, we came up with a decision framework that pulled out the 4 sentinel decision points that we make on every patient: neurologic, oncologic, mechanical stability, and systemic disease. And while the treatments have changed and advanced in terms of systemic therapy, radiation, and surgery, the 4 sentinel decision points have remained the same. But using this framework, we're able to integrate both evidence-based medicine and new technologies that impact our outcomes in the domains of systemic radiation and surgery. The neurologic and oncologic considerations are made in combination. From a neurologic perspective, we're concerned about myelopathy and functional radiculopathy. But what we're principally concerned about is a degree of spinal cord compression. A scoring system has been validated where 0 is bone only, 1A, B, and C are different degrees of epidural impingement. 2s are spinal cord compression, but CSF seen. 3 spinal cord compression, no CSF seen. And for decision-making purposes, 2s and 3s are considered to be at least traditionally high-grade cord compression. From an oncologic perspective, what we're really concerned about is how we achieve local tumor control. And that's completely predicated on the radiation response. Radiation sensitivity has been completely redefined as we've transitioned from conventional external beam radiation to stereotactic radiosurgery. We have other elements that we use in radiation, including brachytherapy. We have P32 dural plaques, which are now no longer available, but were really meaningful, particularly when we were treating circumferential disease and had a hard time making a conformal plan circumferentially around the dura. Now with volumetric arc therapy and more advanced technologies, it's not so complicated. And so we have less of a need, but these were used, we probably put in over 250 of these plaques to clear dural margins. And then occasionally we'll use high-dose iridium afterloaded catheters for recurrent bone disease. Mechanical instability is a separate assessment because no amount of radiation will stabilize an unstable spine. The SINS criteria was developed to define instability in the neoplastic setting. And I think for radiation oncologists, the most important thing is to recognize mechanical pain, sort of this movement-related or axial load pain, in counter-distinction to biologic pain. The rest of SINS are really radiographic correlates to that pain. Junctional mobile spine have a higher point score than semi-rigid or rigid spine. Bone lesions are classified as lytic, mixed, or blastic. Alignment, subluxation, translation has the highest point score. Vertebral body degree of collapse or involvement, and then post elements, bilateral, unilateral, none. All are weighted by their contribution to instability. 0 to 6 is stable, 7 to 12 potentially unstable, and then 13 to 17 are grossly unstable spines. Here's an example of a patient with 2-level vertebral body disease at the thoracolumbar junction. This is multiple myeloma. And on the SINS criteria, it's a junctional tumor with significant movement-related pain, lytic, and less than 50% vertebral body collapse, which gives us a SINS score of 10. And this is an excellent candidate for kyphovertebroplasty, percutaneous cement augmentation. There's now class 1 evidence, the CAFE study, that shows that doing percutaneous kyphoplasty significantly reduces pain both acutely and durably relative to non-operative management. And so relative to osteoporotic fractures, there's actually very good evidence in the cancer population that kyphoplasty or vertebroplasty are very meaningful treatments in terms of immediate pain reduction, and then that pain reduction tends to be durable. Here's a patient with a plain and burst fracture thoracolumbar junction, but extension into the posterior elements, and that increases the SINS score to 13 with posterior element involvement. When you see a patient with a burst fracture and posterior element involvement, you can't simply do percutaneous cement augmentation of the vertebral body. You have to give them a posterior tension band. This is most commonly done now with percutaneous pedicle screws. Usually fenestrated screws are used so that we can cement augment our screws to overcome the ubiquitous problems of osteoporosis or adjacent segment progression. And this patient additionally got cement and an adjacent level of fracture. But when you see these SIN scores creeping up into the over 12 range, typically it means they have a burst fracture, posterior element disease, and cement augmentation alone will not fix that problem. Typically, they have to have percutaneous or open posterior tension band placed. And again, in our institution, it's now being done percutaneously. It's usually a day stay. And again, we have very good evidence that we can take people from a VAS of 7 to 10 and bring them into the mild 0 to 4 range with this very simple one-day stay procedure. And then this is a patient with a cervical fracture, C1-2, has a significant fracture subluxation, and the SIN score is 16. And this patient can't be done percutaneously. This is an open procedure, occipital-cervical fixation and decompression. But these types of patients, most often we can do kyphovertebroplasty or perc screws, but some patients will still need open surgery for instability alone. And then we get to the last assessment, which is systemic disease and medical comorbidities. Most of our patients get a systemic workup, or we know where they are in terms of their treatment. Survival has been used as a determinant of whether a patient should undergo certainly surgery and often radiation therapy as well. The biologics and checkpoint inhibitors have improved survival for virtually every cancer. And so while we knew almost to the day with chemotherapy when somebody would progress, there's a new biologic and checkpoint inhibitor that's come out every day for virtually every cancer. And all of a sudden, we didn't have any idea how to make those determinations. Here's a single checkpoint inhibitor, nivolumab, compared to standard chemotherapy for melanoma, which more than tripled the survival. And again, for almost every tumor histology, there's a meaningful biologic or checkpoint inhibitor that has changed our survival curves. Joe Schwab at MGH developed the SORG nomogram, which is a predictive model that was developed in the era of checkpoint inhibitors and biologics. And compared to other nomograms or survival determinants such as Tomita and Takahashi scores, this certainly has the highest sensitivity and specificity and the best predictive value It's online. They're very easily acquired metrics for this that can be plugged in, and at least gives you a sense of where that patient is, independent of whether they have more biologics or checkpoint inhibitors in the offing. And then finally, also at MGH, John Shin has been very dedicated to developing frailty indices for surgical patients undergoing tumor-related procedures. And they have not been published yet, but they are all about to come out within the next few months. So you can not only get a survival nomogram, but also whether that patient medically can tolerate that procedure that you potentially propose. And these have been very meaningful advances in determining whether patients are candidates based on systemic disease and their medical comorbidities. The neurologic and oncologic consideration in the NOMS framework are made in combination. From an oncologic perspective, again, we're concerned about radiosensitivity to conventional external beam radiation. There are sensitive and moderately sensitive tumors, such as the hematologic malignancies and the hormone-driven solid tumors, breast and prostate. The remainder of the solid tumors are basically radioresistant. And then again, from a neurologic perspective, we're concerned about myelopathy, functional radiculopathy, but what we're principally concerned about is the spinal cord compression using our scoring system. How do we make decisions? Well, for the sensitive and moderately sensitive tumors, regardless of the degree of spinal cord compression, we'll typically put those patients on high-dose steroids and take them to conventional external beam radiation with the expectation that the tumor will apoptose and decompress the spinal cord. The exception are moderately sensitive tumors with high-grade cord compression and myelopathy. Those patients we do take to surgery because we don't think we get an effective decompression in a timely enough fashion to actually be meaningful for neurologic recovery. So if we're myelopathic or have Cauda-Equina syndrome, breast, prostate, moderately sensitive tumors, we are going to take those patients to surgery. For mildly to highly resistant tumors, we've seen very poor responses to conventional external beam radiation, and these patients are typically taken to stereotactic radiosurgery in our institution, 24 Gray single fraction or 24 to 30 Gray in 3 fractions. And then for the moderately to highly resistant tumors with high-grade cord compression, those traditionally have been the patients that we've taken for separation surgery, followed by radiosurgery. More recently, and I'll show you this data in a minute, the grade 2 compressions are now being treated with hypofractionated radiation with very good outcomes, which really in our institution leaves only the high-grade cord compressions for separation surgery, followed by radiosurgery. One caveat is that if you have a patient who has any degree of myelopathy, it becomes an urgent or emergent to get that patient to treatment as expeditiously as possible. Some patients who develop myelopathy or Cauda-Equina syndrome will very gradually sort of decline over weeks to months. But the more common scenario is once they start to get neurologic impairment, very often they may be a D one day or even normal strength and just a wobbly gait, and then fall right off the cliff, even on high-dose steroids. And so once you see a patient who's myelopathic, even if it's myeloma and lymphoma, which you potentially are going to irradiate, you have to do it in an expeditious fashion on high-dose steroids and not let them fall off this cliff. Because once they're in Asia A, once they're 0 out of 5 in the lower extremities, it's very unusual and very hard to get recovery unless you get them there very quickly and get a little bit lucky. So we want to catch them here and not catch them here in terms of treatment. But here's a patient with multiple myeloma, very high-grade cord compression at T10 to 12. We put this patient on high-dose steroids. They were in Asia C, 3 out of 5 in the lower extremities, 3 grade times 10. At 10 days, we got a re-image, and the tumor completely apoptosed, decompressing the spinal cord and recovering the patient to normal neurologic function. If you're going to irradiate a patient with high-grade cord compression that looks like this, admit them to the hospital in case they decompensate during the radiation and need to go emergently to surgery. Don't let them go home and start the radiation therapy because, again, if they progress, timing in terms of getting to surgery is really important. It's not that often that they will, but occasionally they will. So please admit those patients to the hospital if you're going to take that scenario to radiation. There's still a role, again, for conventional external beam radiation for the radiosensitive tumors, but for radio-resistant tumors with minimal or no spinal cord compression, most institutions are now going straight to stereotactic radiosurgery. Arjun, I'm sure, will present his data on that. Here's our series from Memorial of a little over 800 tumors, mostly for radio-resistant tumor histologies with ESCC 0 to 1C, so no spinal cord compression and median follow-up of 2 years. Contours were according to standard guidelines. The prism dose was 18 to 26 Gray single fraction, but dose was analyzed as a continuous variable, and an optimal cut point was used to establish a low versus high dose cohort. The median dose planning target volume in the low dose cohort was 16.4 gray versus the high dose cohort 22.4 gray. The only significant factor that influenced local failure was a dose of radiation. So in the low dose cohort at a year, there's only a 5% failure rate, which isn't too bad, but at 4 years, it increased to 20%. In the high dose cohort at 22.4 gray, less than 1% at a year, and it was fairly durable going forward. Why is this number important? Because so many patients now, because of the biological checkpoint inhibitors, have improved survival. And secondarily, we're now treating a lot of patients with primary tumors, such as chordoma, at very high dose radiation. The durability of that response really does matter. And so ultimately, for patients who are going to live a long time, we think that dose does matter. These responses are both histology and volume independent. So we overcome radioresistance with high dose per fraction radiation. Here's our series of grade 2, which was recently published. Instead of doing single fraction radiation, these were all hypofractionated at 8 to 10 gray times 3 to 5 fractions. The 1-year incidence of local regional failure was 10.4%, increasing to 22% at 2 years. And the cumulative incidence of same level surgery requirements were 6.8 at a year, increasing to 14.5% at 2 years. So we give up a little bit of the durability of that response, but we're not taking these patients to surgery. And again, for patients who are sick or debilitated and can't tolerate it, this may end up being a very meaningful adjunct. We are now starting to treat higher grade cord compression, grade 2s without surgery in some instances. How has radiosurgery changed the surgical paradigm for patients with minimal or no spinal cord compression? Here's a patient with a T2 solitary renal cell metastasis with ESCC 1B. If you judge this by the Tomita Takahashi scores, this would get a grade of 4 and would be recommended for en bloc resection. This is a massive surgery. Operative times are 15 hours. Blood loss reported in the literature anywhere from 5 to 15 liters. Local control is about 87% with surgery alone, en bloc resection. And then the median time to progression in these patients is about 11 months for distant metastases. And so it was meaningful in a time where we didn't have really good radiation for the radioresistant tumors. Now with radiosurgery, do 20-minute treatment time, no blood loss, and upwards of 98% control. And so this paradigm, I think, across the international spectrum is beginning to change as people have access to radiosurgery rather than this really morbid type surgery. Much of the past decade, both in our institution and certainly Arjun Segal has been a major contributor to determining dose constraints for organs at risk. The most important is to the spinal cord, a cord Dmax of 14 gray. We have less than a 0.5% chance of creating myelitis. But it's this dose constraint on the spinal cord that prevents us from treating high-grade cord compression. And that's predicated on a number of issues. Mike Lovelock did a dose failure analysis where all local failures receive less than 15 gray to a small percentage of the planning target volume. If our cord Dmax is 14 gray with a 10% per millimeter fall off, then either we give a cytotoxic tumoral dose that overdoses a cord, or we underdose at the margin of the cord where we need the greatest control. Secondly, the resolution of soft tissue disease can take months, unlike that myeloma I showed you. So we got no effective immediate decompression of epidural disease. And finally, Samru tried radiosurgery for high-grade cord compression. 50% lost to follow-up in this series, but of those who were followed in the radioresistant tumors, there's a 20% risk of neurologic progression. So at least to date, for high-grade cord compression, certainly the grade 3s with radioresistant tumor, we go to surgery followed by radiation therapy. Much of this is predicated on the Patchell study, which was published in Lancet 2005. It was a prospective randomized trial of solid tumors looking at high-grade cord compression with myelopathy, but that myelopathy was sometimes defined as simply biologic back pain. They compared surgery and conventional external beam to conventional external beam alone. And in every outcome variable, surgery was better than radiation alone. And based on this study and a number of other studies, the Spine Oncology Study Group made a strong recommendation for patients with high-grade spinal cord compression due to solid tumor malignancy undergo surgical decompression and stabilization, followed by radiation therapy. The question became, what kind of surgery, what kind of radiation? With the integration of stereotactic radiosurgery, the neurologic goals of spinal cord decompression for neurologic salvage and using screw rod systems to provide mechanical stability remain the same. What changes the oncology? Again, tumor control is completely predicated on the radiation response. And when we only had conventional external beam radiation as a postoperative adjuvant, we often did maximally cytoreductive surgeries, either gross total resection or that en bloc that I showed you. With the institution of stereotactic radiosurgery as a postoperative adjuvant, maybe all we have to do is reconstitute the thecal sac to create a better target for the radiation, and that became known as separation surgery. So here's an 86-year-old with papillary thyroid, Asia C, massively hypervascular tumor that underwent preoperative embolization. They have very high-grade cord compression with 3-level vertebral body disease. And I would submit to you, there is no possible way to get this patient to a 3-level front-back surgery. With separation surgery, traditionally we've done a long posterior fusion, 2 levels above and below the index level of epidural disease. We take a high-speed drill and drill off the bone in the lamina, superior and inferior facet joint. We find the margin between normal dura and the tumor and strip the tumor off of the dura, come around anteriorly, strip the posterior longitudinal ligament to get a margin on the anterior dura. And ultimately what we're trying to do is reconstitute the thecal sac. We take this very high-grade cord compression and simply decompress the area around the spinal cord. We left all this tumor behind, did a long posterior fusion, gave this patient 8-grade times 3, and had fully controlled disease 2 years out. Patient recovered ambulation. Essentially, we gave this patient a surgery that they could tolerate and then got them to meaningful radiation to get tumor control. In terms of separation surgery, 75% of our non-ambulatory patients regained the ability to walk, and overall 90% were ambulatory. In terms of patient-reported outcomes, using this paradigm of separation surgery followed by radiosurgery, what we now dub hybrid therapy, both in terms of BPI and metastasis, both pain and general activity are significantly improved. In terms of whether it's meaningful to add this as an adjunct, this is the only series that looked at conventional external beam radiation longitudinally as a postoperative adjuvant. It was published by Claycamp Sammy in 1998. Most patients underwent very aggressive resections of their tumor, followed by conventional external beam radiation, and the local control was only 30% at a year. And one of the biggest predictors of recurrence, of course, was tumor histology. If you had radio-resistant tumor histology, you weren't going to get control no matter how aggressive you were with your surgery. Here's our series of separation surgery followed by radiosurgery in 186 patients. Most were operated for high-grade cord compression with radio-resistant tumor histologies, and fully 50% had failed prior radiation therapy. There were 3-dose strategies: high-dose single fraction, high-dose hypofractionated, and low-dose hypofractionated. The 1-year cumulative incidence of recurrence was 16%, but if we gave a high enough dose single or high-dose hypofractionated radiation, we had less than 10% recurrence at a year, and that response was fairly durable. And again, we overcome radioresistance with high-dose perfraction radiation, so there's no association with radioresistant tumor histology, prior radiation, the degree of preoperative epidural extension. We've tried to make advances in radiosurgery, again, to make it less invasive and more tolerable for a really frail and sometimes very sick patient population. Our biggest complications have been hardware failure, where our rates with separation surgery are actually relatively low at 2.8%. And the wound dehiscence and infection rates are better with radiosurgery than with conventional external beam radiation, but still not low enough. We've made some improvements to separation surgery. I think the biggest recently is using short segment fenestrated short segment cement augmented screws. Traditionally, with either percutaneous or certainly with the open separation surgeries, we've done these very long constructs, which obviously adds to the morbidity of the procedure. Now that we can use cement augmented screws at adjacent level, hold fixation against osteoporosis or adjacent segment progression, we're very comfortable, again, even with separation surgery, going single level above or below with cement augmentation. We're making a greater effort to do minimal access surgery. About 20% of our cases are now done with tubular retractors. We're starting to look at endoscopic decompression. Here we did an osteoid osteoma with the endoscope fully, but we're now trying to see if we can sneak in through the neural frame and to do decompressions with the endoscope. And we're now just beginning to integrate the Da Vinci robot, mostly for paraspinal schwannomas and ganglioneuromas. But as they get more advanced, particularly with the integration and development of drills for these robots, we think there may be a greater role for these going forward in terms of metastatic and potentially the primary tumors. And then in terms of postoperative length of stay, these enhanced recovery after anesthesia protocols have reduced our hospital stay a full 24 hours. So I think all of this is being worked on to reduce the morbidity when we do have to go to surgery prior to giving effective radiation therapy. And in terms of our minimal access surgery, again, we have significant improvements in terms of pain and general activity based on BPI and the Metastasis symptom inventory. So in the NOMS framework, again, there is still a role for conventional radiation for radiosensitive tumors, regardless of the degree of cord compression. And again, the exception are myelopathic patients with breast and prostate who often will undergo surgery prior to radiation therapy. For radio-resistant tumors, ESCC 0 to 1C, and now creeping into the 2 range, we're starting to do standalone and definitive stereotactic radiosurgery. For radio-resistant tumors with high-grade cord compression, grade 3s, and many grade 2s, we're still using this very simple separation surgery, now with short segment fenestrated PMA screw-augmented screws, followed by radiosurgery to get local tumor control. Remember that instability is a separate assessment, and once you determine instability, there are often candidates for kyphovertebroplasty, PERC screws, open surgery, or potentially bracing. And then finally, everything is predicated on what the patient can tolerate from a systemic disease standpoint and their expected survival. So we go back to the 66-year-old male with a history of renal cell, this biologic back pain for 3 weeks, Asia C, renal cell extending into the renal vein and some pulmonary nodules. In our NOMS framework, Asia C, high grade with a radio-resistant tumor. Mechanical stability is 4, does not come into, the SIN score is 4, does not come into play, and they're cleared medically and from expectation of survival to undergo anything that we recommend. This patient would be put on high-dose steroids, embolized for a hypervascular tumor, and then taken for really simple separation surgery. Again, we used to use these long segment fixation. This would now be done short segment. What of this patient is Asia C, high-grade cord compression and lymphoma. Again, exquisitely radiosensitive tumor. They're not unstable, so that doesn't come into play. But remember, a lymphoma patient who has an unstable spine does need a procedure. It's not enough to treat that tumor. But in this case, the tumor is lymphoma, incredibly radiosensitive with high-grade cord compression, not unstable, and can tolerate anything. And this patient, we would typically put on high-dose steroids and treat with radiation, but would bring them into the hospital for this treatment. And finally, this is the patient who comes into your emergency room. They're an Asia C with very high-grade cord compression, but have no history of cancer. The tumor histology is completely unknown, and therefore you don't know the radiation or chemosensitivity of that tumor. Now, there's high probability in this setting that a patient who comes with an unknown cancer is going to have a hematologic malignancy, but basically we're not going to wait for that diagnosis. The simplest and most straightforward thing to do is take them to surgery and get them out of trouble. Don't let this stand on ceremony that if it's myeloma, you should irradiate it. The simple thing to do is get them out of trouble and then get them to effective therapy afterwards. The people who treat a lot of primary bone tumors would argue that if this is chordoma, if you've ruined the ability to get control of this tumor. The problem is if you have high-grade cord compression with chordoma, you can't do an en bloc wide resection, and we do have excellent control rates with follow-up adjuvant or postoperative adjuvant radiation in this setting with chordoma. So don't ever stand on ceremony with a patient like this. And thank you very much for your attention.
Thank you very much, Dr. Bilski. That was a tremendous overview of how to organize the flow for treatment, and a very nice discussion about the techniques that you employ, you use. So now I'd like to invite Dr. Peter Gertsen to speak to us about the principles of radiosurgery for spine. He is, as has been already acknowledged by Dr. Bilski, one of the pioneers in the world for spine radiosurgery. So Dr. Gertsen is a professor of neurological surgery and radiation oncology at the University of Pittsburgh. He received his undergraduate degree at the University of Virginia and completed his medical degree at the Johns Hopkins School of Medicine. Later on, he completed his residence training in neurosurgery at the University of Pittsburgh, also a Master of Public Health degree from the same university, and completed his fellowship in spine surgery at the University of Pittsburgh. He has been working there since 1999, and he is he also is a co-editor of the first spine radiosurgery textbook in 2015, and he serves in the editorial boards of multiple important neurosurgery journals such as Neurosurgery, Spine Journal, Journal of Radiosurgery and SBRT, Neurosurgical Focus. He also has been awarded in numerous prizes, just to mention one, the Pittsburgh Best Doctors in 2018-20. He is world renowned by all the work he has done to prove how radiosurgery really changed the field in the management of these tumors. And he currently uses the variant tuning platform for radiosurgery. So thank you very much for joining us today.
Oh, thank you very much, everyone. Can you hear me okay? Just to confirm?
Yes.
Okay, excellent. Just wanted to confirm. So what I've been tasked to do today is to bridge the first speaker, Dr. Bilski, and the last speaker, where we're moving from open surgery to pure radiosurgery. And that is what I'm going to do today over the next 25 minutes, is to see where we came from and then where we are headed. Just because my first speaker is from New York City and the third speaker is from Toronto, where everyone is very familiar with those cities, I just wanted to let everyone, make sure everyone knew that Pittsburgh falls somewhere in between, but many people don't know where we are located. We are on the route or the origin of the Ohio River in what is considered the Midwest, and we are called the City of Bridges. So as Dr. Bilski showed this case, that he and I, over the past 20 to 25 years, have developed the ability to perform these major surgeries, but we quickly found that there was a price to pay. The first peer-reviewed manuscript that Dr. Bilski and I ever wrote together was not on radiosurgery, but it was on the complications of open surgery. So we discovered at the same time that the morbidity associated with these surgeries was very high, and there had to be another way. And it was no accident that 20 years ago, there was the development of radiosurgery in order to avoid these major complications. Touched base on the definition of spine radiosurgery, and Dr. Segal, for the third talk, will go into further detail about the definitions of spine radiosurgery. But as was stated earlier, we are talking about high dose fraction per fraction radiation. There are many acronyms, SRS, SBRT, SABRE now, but we are all talking about the same thing. We are talking about cytotoxic or ablative tumor doses that is sparing normal tissue tolerance. Indications for spine radiosurgery has definitely evolved, and over the next few minutes, I'm going to show you where we came from and where we are today, and then end with where we are heading with radiosurgery as we integrate radiosurgery into the multidisciplinary approach to patients with spine metastases. We are using radiosurgery more and more as a primary treatment modality. So the patient on the right side who has an asymptomatic but PET positive breast cancer, we know with oligometastatic disease, as Dr. Bilski showed, where we can have excellent long-term local control of these tumors, improve survival, over 20 years ago. In 2005, some of the pioneers at Georgetown University Hospital with the CyberKnife showed that these patients had a rapid improvement in pain scores. And not only was it a rapid improvement, but it was a long-term improvement. 53 patients with a mean follow-up of 1 year, significant and durable pain relief. And it was these sorts of smaller studies at this institution and others that lent us the credibility to keep going and push this in our patients. So now, fast forward to 2017, when the ISRS practice guidelines for SBRT and SRS for de novo spine metastases, as you can see here, where the recommendations were to use and employ SBRT and radiosurgery for oligometastases, for radioresistant histology, for paraspinal extension contiguous to the spine. But as Dr. Bilski emphasized, that for patients with unstable spines with spinal cord compression, radiosurgery was not, and continues to not be, the primary treatment modality, but perhaps a secondary and neoadjuvant treatment. Well, I should say adjuvant treatment. Now, most recently, we and others worked together to publish the radiosurgery and radiotherapy for spinal oligometastases. It was a systematic review of nearly 5,000 lesions, and what we documented was that single fraction radiosurgery resulted in superior local control, and that these patients, not only superior local control, but especially with long-term survivors. So the current recommendations, going back, circling back, is that we feel that radiosurgery in 2021, it's very safe and very effective with durable symptomatic response and local control for even radioresistant histologies, regardless of prior fractionated radiotherapy. And radiosurgery should be considered over conventional fractionated radiotherapy for the treatment of solid tumor spine metastases in the setting of oligometastatic disease and radioresistant histology. We have essentially moved away from en bloc resection for these tumors. And so now we know that today, for histology-specific tumors such as melanomas, where radiosurgery has been incorporated into the treatment algorithm up front of the care of these patients. We're not waiting to refer these patients to neurosurgeons and radiation oncologists for radiosurgery late into the course of the patient's treatment. We have integrated radiosurgery into the upfront management for these complex patients. I want to share with you some of the data from different institutions and the multi-institutional collaboration that we have available to us to support radiosurgery for large-scale clinical evaluations. This was the largest multi-institutional analysis to date from 8 institutions from three different countries, 387 cases, a 2-year local control rate of 84%, no high-grade toxicities, adverse events were rare, and the development of compression fractures was 4%. Why a local control rate of 84% and not 90 to 95%, as is published in some of the smaller institutional trials? I think it's because this is all comers, and we are still seeing patients and treating patients who have failed surgery and failed fractionated radiotherapy. But dive deeper into the results, that 82% of patients had significant pain prior to the radiosurgery, but that there was a tremendous improvement in this pain after radiosurgery, and the pain improvement occurs sooner than with other modalities and lasts longer compared to conventional fractionated radiotherapy. There have been studies looking at the 5-year outcomes, because as we have treated these patients over the last 2 decades, we know these patients live a long time. We have transformed them into almost chronic patients, and I have many patients who I have treated now for 20 years with bone-only breast cancer and other oligometastatic disease. This was from several years ago from the Sloan Kettering group, where they showed that a significant amount of these patients survived and were 5-year outcomes, and only 4% required cement augmentation for symptomatic fractures. We are also employing salvage radiosurgery after radiosurgery. This was from Arjun and his colleagues in Toronto, where we are finding that as patients are living longer and they do have failures of local control, we can achieve local control rates as high as 70% and sometimes even higher with our newer techniques and understanding of contouring in patients who have even had prior radiosurgery. And I think that the future where we are heading is, as part of the including radiosurgery into the multimodality treatment of these patients, is really to combine radiosurgery with systemic therapy. This is an article from the Cleveland Clinic group, where there have been pioneers of looking at VEGF inhibitors and combining that with radiosurgery, where 90% of their patients had pain at 12 months, a cumulative incidence of local failure of only 4%. So a local control benefit with the addition of these systemic therapies to radiosurgery. And can pain outcome be improved as well by targets that had all received prior fractionated radiotherapy. And what we found was a 12-month local control rate of 83%, compression fracture rate of only 4%, and no case of spinal cord or other neurologic deficits. So we know now that radiosurgery can be employed very safely and effectively in patients after conventional fractionated radiotherapy. Just looking a little bit deeper into this, that these 90% of these patients had pain prior to radiosurgery, a 74% clinical improvement in pain, and only less than half of these patients reported any pain after radiosurgery. Here in Pittsburgh, we have been very interested in late toxicities of these radiosurgery because we have been doing this for 20 years now and have followed these patients very carefully. We are fortunate that in Western Pennsylvania, our patients don't move around very much like they do in other parts of the country and other parts of the world. And so we are able to track them. This was at looking at 5 and 10-year rates, where we have found a very low rates of late toxicity in these patients. A word about single versus multiple fraction radiosurgery. Dr. Segal is going to dive deeper into this, but what we have found in our experience is that we have not found a clear advantage of 1 versus 3 or 5 fractions for our patients. If we feel comfortable that we can proceed safely and effectively with single fraction radiosurgery, we try to do that for patient convenience as well as resource utilization. But when we are concerned about the dose to the neurologic structures, especially the spinal cord, we will fractionate these patients. With lots of experience, we have looked at our experience and others. This is from Arjun's group again, looking at the patterns of epidural progression following post ISRS and the implications for target volume delineation. We have learned over time where the patterns of failures have been, where we should keep our doses higher. And initially, when we started, we were very concerned about the maximum doses to the spinal cord, and we have become more comfortable increasing our doses and increasing our target volumes to decrease the rate of progression and failure. So we even have a much better idea, and this was a nice study from the MD Anderson group looking at a prognostic index to stratify survival of radiosurgery. So we have a better understanding of who are the best and ideal patients for radiosurgery for spinal metastases. Regarding the RTOG 0631, we have not yet published the conclusion of the phase 3 trial. It was presented at ASTRO 2 years ago, and the manuscript is in publication. But just for those of you who are not familiar, this was a study, randomized 240 patients, looking at either radiosurgery 16 to 18 gray versus an 8 gray single dose. The issue is that most of our patients do not receive 8 gray single dose for fractionated radiotherapy. They are, or for a single dose, they would be getting conventional fractionated radiotherapy. Now, moving on to the assessment of the response to radiosurgery, because now that we are following these patients or treating these patients, we have to have a better understanding of how we are following these patients radiographically. And we do have a publication of the International Consensus for SBRT planning, image-based local tumor response, pain responses, and imaging follow-up frequency. And this is all available as part of the Spino group. So this was a consensus criteria for imaging and clinical response so that we can all communicate equally on how these patients are being treated up front and how we are following them clinically and radiographically. To shift gears to the adoption of spine radiosurgery, in my opinion, it is very similar to the adoption of intracranial radiosurgery that the entire audience is very familiar with. It parallels the way in which radiosurgery has been incorporated into the multimodality approach to intracranial lesions. Most importantly, it avoids open surgery completely in many of these patients. We alter the actual approach, the extent of resection or approach, as Dr. Bilski so nicely showed, and I will show more in a moment. We integrate radiosurgery now into the systemic therapy, and we use radiosurgery as a boost after conventional fractionated radiotherapy for bulky disease or radio-resistant tumors. However, there are issues that are certainly unique to the spine. There are the issues of spinal instability and how we combine these patients with more minimally invasive procedures. So today, a typical patient here and hopefully around the world, a patient with this is a farmer with some minimal pain in his back. He was found to have a recurrence. He's had prior conventional external beam radiation. In the past, we really didn't have anything to offer this patient. He didn't need surgery. He doesn't, giving him more radiotherapy is not very helpful. But we have the ability to treat this now with radiosurgery. So here we would use 18.5 gray in a single fraction. Perhaps currently in the future, we will be adopting Dr. Segal's 2-fraction approach that we have certainly used for a renal cell metastasis, but that's how we can do this safely and effectively. We and others work together on the spine oncology study group, the SIN score, as Dr. Bilski said or mentioned, of using spinal instability for any patient with spinal metastases. So at what we have patients with that we used to know they absolutely required surgery, they would be sent over to the neurosurgeon or orthopedic surgeon for major surgery and then come back to the radiation oncologist several months later. Now everything is different. We are looking at these patients in a multidisciplinary fashion up front. We look at the SIN score and we decide who needs surgery and how we can integrate radiosurgery into these patients so that we can use more minimally invasive techniques or maximum techniques and then incorporate radiosurgery. So even the National Comprehensive Cancer Network here in the United States, looking at the clinical practice guidelines, has incorporated vertebral augmentation and surgery or radiosurgery into the paradigm for metastatic spine tumors. We are combining percutaneous fracture reduction, something that's been particularly interested, that I've been interested in, looking at mechanical pain control and tumor control and combining both at the same time. So very early on, we realized we could take these patients, avoid major surgery, put cement in. At the time, we didn't really have good percutaneous techniques of instrumentation, so we placed cement. We were able to achieve mechanical pain control and tumor control all at the same time. Now we've developed much more minimally invasive spine techniques. These can be done through small ports. Before putting in cement, we can cavitate and remove the tumor. Now we have what's called an osteocool radiofrequency ablation system, where we can ablate with radiofrequency the tumor, then place cement, then follow up with radiosurgery. So that radiosurgery is absolutely a surgical tool, absolutely identical to the way that radiosurgery is a tool is a surgical tool in the management of intracranial pathology, especially skull-based pathology. A case example of a 70-year-old woman with a renal cell carcinoma. When I trained as a resident, this would be a death sentence for this patient. She would never survive an en-bloc resection, but now we can simply perform a cement augmentation procedure. We follow up with 22 gray in a single fraction shown here, and 9 years later, she is still playing golf in North Carolina and enjoying a normal, active life. This is a complete transformation of how we treated these patients before. So we know today what can be treated and what cannot, as Dr. Bilsey showed with the criteria. But how about with these patients? And that leads us to what he showed, the concept of separation surgery. So as surgeons, we always think about what we can do with surgery to place screws, decompress, and then follow up. We can turn a patient from this into this in order to allow for radiosurgery. So that minimal access spine surgery, where we can decompress and stabilize, that radiosurgery has become a part of the surgical approach up front. We are trying to avoid these patients from coming into the hospital, from having major open surgeries with major complications, and getting them onto better systemic therapies and radiosurgery. Does it work? Absolutely. As Dr. Bilsey and his group showed 8 years ago, combining surgery and radiosurgery is a successful strategy. Now, what we have been doing since the documentation of this strategy is to see and to determine who are the best patients. And as surgeons, we are finding that these patients do better with radiosurgery than conventional radiotherapy. We and others have shown that the risk of complications after prior radiosurgery is no greater. In fact, it is less, because we are radiating just the tumor and not the entire field with conventional radiation, so that there is a less likely rates or lower rates of hardware failure and higher rates of fusion. And that leads us to titanium instrumentation and methyl methacrylate, where many of our patients now have radiosurgery. We show that nearly a third, now almost half of our surgery patients have some of our spinal implants. Our radiation therapists love it because it allows for easier setup of these patients with the instrumentation, so we can treat these patients. And we can use techniques such as myelograms for target volume delineation when there's a lot of hardware, where it's very difficult to see what can be seen here. But with a myelogram, you can easily identify the neural elements, easily identify your GTV, your CTV, your PTV, and deliver these doses very safely. So to end with, I feel that the role of radiosurgery has been a major paradigm shift. For 20 years, we have slowly and carefully documented that for oligometastatic disease, just like in the brain, we can agree that radiosurgery is a much better treatment option for these patients. Tomorrow, where are we headed? These are with Bilski scores 2 and 3. We can perhaps completely avoid open surgery once and for all. There will always be patients with spinal cord compressions and neurologic deficits who do need open surgery. As Dr. Bilski and I have emphasized, we have changed the way that we approach these patients surgically. But here's a patient who had surgery by our orthopedic surgery colleagues for a lung metastasis at T10, developed a DVT, was anticoagulated, could not have any more open surgery, was Coumadin dependent, had this recurrence, and what we decided to do was to treat with radiosurgery. When I first brought up the films to review them at 3 months, I thought I was looking at the preoperative film, not the postoperative film. And literally, we are able to achieve now over and over again from here to here with radiosurgery. We can decompress the neural elements with radiosurgery. To end with the importance of multi-institutional, multinational collaboration. Over the past year, it's been difficult for us to meet face-to-face and discuss our techniques, but hopefully with these webinar formations and in the future, we can sit down and see what we are doing here and at other institutions as well, long before our articles are in the peer-reviewed literature, and we can quickly adopt these new techniques. So I want to end with a small shout out for Argentina. I feel that in a similar fashion to the way that radiosurgery is today an essential part of the treatment paradigm for intracranial tumors, radiosurgery has become an essential tool in the multimodality treatment for spine metastases. We are only at the tip of the iceberg. For those of you who don't know, this is Perito Moreno in the very south of Argentina. It's one of the only glaciers where you can actually on land go up to it. You can climb on top of it. It's an absolutely beautiful place on Earth to go and to see a glacier and to walk on a glacier up front. And I feel like we are only at the tip of the iceberg. With radiosurgery, we have a lot to know about and a lot to learn and collaborate. Thank you all very much.
Thank you, Peter. It was very nice, wonderful lecture as always. Thank you very much. Very nice reference to Argentina. Politically correct. No soccer involved here.
Yeah,
so
yes, mi equipo is Argentina Juniors. My father played professionally for Argentina Juniors, but I wasn't going to wear that sweatshirt today. So maybe next time, if you allow me.
Of course, allowed. Thank you. And now I'd like to invite our third speaker of the day. That's Dr. Arjun Sagal. And it's really a pleasure to have Arjun here with us. He's currently an ISRS officer here, and he has been working so hard as usual, helping the ISRS in all the guidelines publications. Dr. Sagal trained at the University of Toronto in radiation oncology. He concluded his radiosurgery fellowship at the University of California, San Francisco. He has published over 500 peer-reviewed papers, including publications in high-impact journals such as Journal of Clinical Oncology, Lancet Oncology, and the New England Journal of Medicine. Under his leadership at the Sunnybrook Odette Neuro-Oncology Program, he has been awarded more than $42 million in funding for research. And he is currently professor at the Department of Radiation Oncology and Surgery at the University of Toronto. He's also the director at the Sunnybrook Cancer Ablation Therapy of the therapy program, and he is the director at the Sunnybrook Radiation Oncology Center. He has He also serves as Deputy Chief of the Department of Radiation Oncology at Toronto University. And he is currently dedicated in the development of MRI guided LINAC applications and also the joint combination of focused ultrasound technology with radiation. He uses different technologies there at the Toronto University, the MRI brachytherapy suite, MRI LINACs, and the gamma knife icon technology. So it's really an honor to have Arjun at the ISRS Latin American series here speaking with us. Welcome, Arjun.
That's great. Thank you very much. And just let me know, can you see my screen fine?
Screen and slides.
Screen and slides are okay?
Yes.
Excellent. Okay, great. So let's start. And essentially, I was asked to speak about single fraction versus hypofractionated stereotactic radiation. And it's a great topic, and thank you again for inviting me to speak here. Just my disclosures. So the idea behind dose and stereotactic body radiotherapy is really what we're going to get into. And I've been certainly experienced with various dose fractionation schemes, and I use 24 gray in 2 fractions primarily. And you can see in this position, this patient with a renal cell metastases where it couldn't have surgery because the artery of Adamkiewicz runs through it. We treated this patient with 24 gray in 2 fractions and had a spectacular response. Now, not always do you see this type of response, and we tend to see it more in vascular tumors. We certainly enjoyed long-term local control, but actually tumor shrinkage is actually quite rare, but it is an effective dose. And when we started talking about dose, we initially were comparing to conventional radiation, like 30 gray in 10 or 8 gray in 1, 20 gray in 5. And SBRT really represents an escalation of that stereotactic, of the biologic equivalent dose, to gain higher rates of tumor control and pain control. And this is where the field was about 20 years ago. And really where we're going to be is going to be talking about what the best fractionation scheme is. And I'll tell you how I came with 24 gray in 2 is that I was doing a lot of 3 fractions in San Francisco where I trained with David Larson. And then I started using the 24 gray in 1 approach where Sloan Kettering was publishing these data, but the fracture rate was high. And therefore I said, well, look, why don't we try 2 fractions and still use 24, and it's going to be in the middle, and let's come up with that fractionation scheme. So I developed it, and I'll show you the trajectory of the outcomes with 24 gray in 2 fractions. But why fractionate in the first place? Why not do single fraction for everybody? Well, the pros of fractionation, and we really learned it from the brain, in particular in surgical cavities or big brain metastases, is that it's safer on the normal tissue due to repair of the normal tissues in between fractions. There's technical safety, which may be more important in spine radiosurgery than in brain radiosurgery, as fractionation blurs some of those dosimetric uncertainties. It may be more effective due to tumor reoxygenation and redistribution, and you can essentially safely dose escalate to achieve an equivalent biologic effective dose to a single fraction, but maintain more safety. The cons may be tumor repopulation and tumor DNA repair between fractions, and that's more of an issue when you're talking about 6 or 7 weeks of radiation. Now, you may have changes in tumor dimensions between fractions, which may be more important in the situation of epidural disease, and we may not be maximizing some of these new radiobiologic effects by not giving very high dose per fraction, single fraction radiation. And what are those radiobiologic effects? And one of the areas in terms of new radiobiology really originated from Sloan Kettering, looking at this phenomena of treating with greater than 8 to 10 gray per fraction, where you're inducing tumor endothelial cell apoptosis, so enhancing the apoptotic response. And ultimately, this initial work has morphed into a combination of tumor endothelial response, resulting in extreme hypoxia within the tumor and essentially an ischemic cell death. So it is an evolution, I think, in play, but we certainly do believe in this radiobiology. Now, the radiobiology is such that we're talking about greater than 8 to 10 gray per fraction. So when you're talking about 24 and 2, that's 12 gray times 2, and you may be maximizing the radiobiologic effect even in the tumor endothelium by hitting it with 2 high dose per fraction radiations. And this leads us to some of the issues in terms of the immune response. And Mark talked about this, where more and more our patients are getting immunotherapy. And what these data show in vitro is that if you're going to give 2 fractions of high dose per fraction radiation, you're going to do better in terms of inducing immune response and lowering the anti-immune response within tumor cells known as Treg cells. And that's better than if you were to give 15 gray in a single fraction. Now, the technique. So this is, I use a LINAC platform. It's very important that we understand that we maximize the technology to ensure minimal motion. So we immobilize patients in a near rigid body immobilization system. You need to use thin slice CT, thin slice MR, preferably on a MR simulator, and you want to use IMRT or VMAT. The issue is sub-centimeter MLC, and it should be 5 millimeters or less, an appropriate image guidance protocol. And in the beginning, you may want to do intrafraction imaging and post-imaging to make sure that your technology is down. And now with treatment times so quick, you essentially can just do your initial image and then treat. And we don't do verification anymore because we know our uncertainty margins. But ultimately, with robotic technology, if you're going to use a LINAC, you want to correct in all 6 degrees of freedom, use very strict repositioning tolerances. And based on this, we actually have a 95% confidence in our PTV of 2 millimeters. So that's our uncertainty margin. So what about spinal cord dose constraints? Because again, when we're talking about single fraction versus hypofractionation, the dose per fraction is a factor in terms of the late effects. So if you hit with a high dose per fraction, you're going to increase the potential for long-term adverse effects. Now, we've understood over time spinal cord dose limits, and it's an evolution. I mean, the initial numbers that I provided in 2013 were an initial guideline, you know, of saying 12.4 in 1, 17 in 2, and we gave 1 to 5 fraction regimens. And as we learned over time and we modeled some of the newer data from Stanford and from Sloan Kettering, as we obtained radiation myelopathy cases from those institutions, we were able to come up with a low risk, higher end of the range dose constraints like 14 gray in 1 or 19.3 in 2. And ultimately, about 4 years ago, I actually had increased our numbers anyway, because I was very comfortable with it. We treated 1,000 patients, and I went from 17 to 18.7. And now with this, we are going to selectively increase to the highest level. I don't do single fraction radiosurgery, so I don't have that experience. I stopped doing that many years ago. But ultimately, this represents a range now that you can think about for your patient. Now, when you talk about our data, and again, I've been doing 24 gray in 2 for a very long time, we enjoy very nice long-term local control rates, 90% at 1 year. But as you get out to 2 years and 3 years, our local control rates start to get about 80% in the long term. Now, what's important here is our fracture rate, and our fracture rate is 10%, and that's been very consistent amongst various institutions that have reported on 24 and 2, and it is a fractionation scheme that's been adopted now globally throughout the world. Now, why is it? Well, one of those issues is not necessarily radiation myelopathy, because if you follow the dose constraints, you should be safe. But the issue really is fracture. And we've learned more and more over time with some joint work with the MD Anderson and Cleveland Clinic that baseline fracture, malalignment, lytic tumor, and the dose per fraction that you use are predictors for fracture. And fracture can be really quite significant for some patients. For example, here, if you fracture down, you're probably looking at an invasive stabilization, given you're at the cervical thoracic region. Now, this is the dose complication relationship, again, going back to the question of single fraction versus hypofractionation. If you treat with 24-in-1, you have a 40% risk of fracture. What I do, 12 gray times 2, you're at 10%. Again, very consistent, but there is a stepwise increase. Now, the Sloan Kettering and Mark's group had reported initially a 40% rate of fracture, but their fracture rate was happening in the long term. And we observed the majority of fractures happening in the acute phase, so within the first 3 months. And why is that? And I suspect that we were not selecting our patients well for initial stabilization. So we were getting the instability aspect of the fractures by hitting it with a high dose of radiation. You destabilize and you fracture. But if you wait long enough over time with high dose per fraction, you're still going to get fractures as a result of long-term radiation necrosis. So you can get it initially or later, but again, the complication relationship is there. So what are the randomized data? Because we've shown you a lot of data that are associated with single institution series or multi-institution series, but we need randomized trials before you can go out there and say, we're going to change the standard of care. So is spine SBRT superior to conventional external beam? And where the data have been presented are really in the de novo situation. So this is a very important first phase 2 randomized study from Germany that randomized patients to 24-in-1 versus 30 gray and 10. And what they showed, and this was powered as a sample size of convenience, was that the complete response rate was actually 40% with the 24-in-1 arm versus 17% in 30 gray and 10. And we love this because this was consistent with everything that we were basing our sample size calculations for larger trials. Now, it didn't achieve statistical significance at 3 months because it really was not powered adequately. And they showed that this was durable at 6 months. Now, what's important also is that they did show that that fracture rate was much higher in the 24 gray in one arm, 30% versus 5% at 6 months. So then comes RTOG 0631. Again, Peter was instrumental